Welcome, everyone, and thank you for joining us today. Before we begin today's webinar, Osteoporosis Canada acknowledges the land that our offices, located in Toronto, are on, is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. My name is Tracie Napoli, Director of Fund Development and MARCOM at Osteoporosis Canada, and I will be your moderator for today. This presentation will provide general information and is not intended as individualized health advice. If you have questions about today's topic, please consult a physician. Now, during the webinar, if you have a question, you can click the Q&A icon at the bottom of your screen and enter it there. We will do our best to answer as many questions as we can during the webinar within the time available. Osteoporosis Canada is the only national organization serving people affected by osteoporosis. The organization works to educate, empower, and support individuals and communities on bone health and in the risk reduction and treatment of osteoporosis. We provide medically accurate information to patients, healthcare providers, and the public. Services include programs and support groups, educational webinars, podcasts, digital tools and resources, all available at osteoporosis.ca, along with additional community resources. Today's webinar is Origins of Musculoskeletal Pain. When you suffer from an injury, disease, or aging, any or all of these can cause pain, stiffness, or other problems with movement and function. I'm now pleased to introduce our presenter for today's webinar, Dr. Kin On Wong. Dr. Wong is an imaging and data scientist at UHN and University of Toronto, investigating the interactions among muscles, bones, and joints in the context of osteoporosis, sarcopenia, and osteoarthritis. His research team uses programming to discover new imaging biomarkers to predict painful musculoskeletal changes in older adults by applying traditional epidemiology and machine learning. His work is funded by CIHR and the Arthritis Society. Dr. Wong is also a member of the Osteoporosis Canada Scientific Advisory Council and leads the CMC Young Investigator Day. Please welcome Dr. Wong.
All right, thanks so much, Tracie, for the introduction. I'd like to thank you all for registering at the Osteoporosis Canada website and watching this webinar today. I'm happy to present to you topics on musculoskeletal pain today. So let me share my slides. All right, excellent. So I'm going to start with some first disclosures. I do receive some federal funding from CIHR, the Arthritis Society, internal awards from the University of Toronto and the University of Melbourne for my research. We're going to start today with discussing a little bit about the anatomy of pain, and then going through how you can talk to your doctor about your pain, different categories and patterns of pain that you could discuss with them, including collateral damage of painful experiences. And then we'll go into a bit more about musculoskeletal pain in general and what are the common causes before we end off with a discussion about treatment options. So first, how is pain developed and how is it felt? Pain is actually a sign that something has happened and something is wrong in your body. It is an essential body function for warning your body of tissue damage and for you to avoid further injury. There is a series of processes through which pain is felt, and this includes transduction, transmission, modulation, sensitization, and it results in your perception of pain. So these are really big words. I'm going to explain each of them. So in the first process of pain, you have a trigger point, something that results in the damage to your tissues. So this is the part of transduction. Your external stimuli, be it a cut or a bruise, any degenerative damages, for example, can stimulate what's called receptors. These are proteins on the surface of cells. And these proteins can turn the signal that you feel from a cut or a bruise into a packaged message to be sent to your nervous system. So you can see in this diagram here, the receptor is something that receives chemical signals, and it turns it into a packaged response. And these messages are then delivered to your central nervous system. So this second part is transmission. So we're delivering these messages from outside of the brain to the brain. However, the message doesn't actually get sent unless it passes a threshold. So you can see in the diagram on the bottom here, there are little bits of messages or packages being created. However, they don't actually trigger a response until it supersedes this threshold that is created in your body. Now, the intensity of pain also relates to how many messages are successfully sent. So you can see the diagram on the top, the person with more sparse packages or signals being sent feels less pain than the individual at the very bottom who have a lot of messages being sent. So the frequency of message delivery correlates with the amount of pain you feel during transmission. Now there's modulation. So your body has these natural chemicals produced by your spinal cord and by your brain that can help you relieve your pain a little bit. It's not going to be perfect, of course, but it will modulate some of the pain that you feel. And then there is sensitization. So over time, that threshold through which you have to meet before your messages get sent to the brain can become lower and lower, and at which point a delivery can be triggered really easily. So this is called sensitization. So this lowers the threshold of accepting messages and is triggered by repeated stimuli. So for example, more bruises, more cuts, or more degeneration that's constantly triggering damage in your tissues can result in sensitization of your nerves. And then finally, when you put all these processes together, we end up with perception. So this is how you perceive or feel pain. And it includes your emotions, whether it be anxiety or depression or suffering from the pain, your natural reaction initially to pain, and also your long-term reactions to pain. And then your rationalizing, so how you conceptualize your own pain. And all of this affects how we think about and communicate our pain. So pain is a very subjective experience. Your willingness to report pain, your endurability of pain, and how sensitive you are to pain, that varies between individuals. So recent research suggests that people have varying amounts of chemicals inside of your brain that regulate pain. And these differences may explain why different individuals experience pain differently. Now, other factors that can change this include the genetic makeup, which really changes the threshold through which messages of pain are sent, and also sex differences. So between males and females, there are differences in these pain thresholds. So now we're going to go into talking about your pain a little bit and review categories and patterns of pain. So the first categorization is the distinction between acute or short-term pain. And this can include, for example, a cut, a bruise, or a burn that resolves with healing, versus chronic or long-term pain. So this is pain that is usually experienced beyond 3 to 6 months. And for example, joint pain, neck pain, or back pain. Now, different kinds of pain require different strategies to fight the amounts of pain that you have. Now, acute pain can eventually also become chronic pain. Now, when does this exactly happen? The body may heal itself after your experience of acute pain, but your brain may continue to perceive pain through the sensitization pathways that I talked about earlier. The genetics and bodily functions and other physiological and psychological functions may also contribute to you developing more chronic pain. Pain beyond the body's normal healing time is considered more chronic pain. And having other medical conditions, especially ones that contribute towards inflammation, can also contribute to chronic pain. Now, the idea of chronic pain can result in emotional and physical damage. On the emotional side, chronic pain results in depression, anger, anxiety, fear of injury, which really changes your behavior in your activities of daily living and your ability to return to those activities. Physically, your muscles can get tense, and then that, I'll talk a little bit later, is another sign of a collateral damage as a result of pain. You will have a limited ability to move around, a lack of energy, and changes in your appetite. So if you experience chronic pain, these are all too familiar to some people. Now, there are different categories or subcategories of pain that we can then discuss. The first is somatic pain. This is bodily pain that originates in the skin, the muscles, the bones, the ligaments, and the tendons, which really is what we're talking about today in terms of musculoskeletal pain. That's what musculoskeletal means. It is described as sharp, usually very intense but short, and throbbing, which means it's repetitive. And then there's visceral pain, or pain that originates from the visceral organs. These are usually described as deep and dull, or longer durations of pain, but not necessarily as sharp. It could be sharp, but it's not always the case. And then you have neuropathic pain, pain that is described as coming from within the nerves. So these are often described as shooting, burning, or stabbing sensations, and they're short and intense, but often traveling along the length of your arms and legs. So for example, if you have sciatica, that is pain that develops in the sciatic nerve, and it travels from your lower back down to your legs. And often neuropathic pain is exacerbated by physical activity. Now, pain can also have different patterns. You can have intermittent versus constant pain. And chronic pain can last for months or years. And during the course, these patterns can vary quite a bit. And in terms of severity, it also changes over time. It's not necessarily increasing all the time. Sometimes it decreases before it increases again. So people with chronic pain are often very distressed and perplexed about why the pain comes and goes, and why in certain situations pain can get even worse. And a lot of the experiences that we feel from chronic pain adds to our emotional challenges with our perception of pain. For neuropathic pain, so again, this is pain that develops from the peripheral or central nerves. There's often a delayed onset because there is a damage to the nerves, and it takes time for it to become worse. Usually it happens in older individuals. It contributes to chronic pain, and it shoots up along the nerve, spanning a larger area where the nerves actually travel in your body. So those are different categories of pain and ways that you can talk to your doctor about pain. Now, as a result of chronic pain, there are collateral damages. Pain results in sustained muscle contraction. So this oftentimes gives you knots in your muscle, and it's more persistent pain. It's a different kind of pain beyond what you usually feel, but it exacerbates your existent pain and causes even more stress and anxiety. The initial damage can also be amplified further and turns into chronic pain. Very often, the collateral damage in your muscles are triggered and causes further inflammation. And the molecules designed to bring the blood and immune cells to the damaged tissue to break it down further causes matrix breakdown in your tissues. There are other sources of inflammation, for example, alcohol, smoking, and food that is high in fat. These could also exacerbate the situation and cause more collateral damage and more pain. Now, there may be individuals asking why I still have lingering pain after my injury has resolved. Now, I already mentioned about sensitization. So the central nerves, when they're already damaged and the sensitization is at a height, the receptors, the molecules, and your pain threshold all become affected. So this culminates in what we call central sensitization, which results in your body being triggered very easily by even small touches or events that aren't usually painful before. So there are some variabilities in your pain perception, and this includes sex. So between females and males, females have machinery to feel pain, but they also have machinery to also deal with pain modulation. There's genetics, gender, including, so sex is different from gender. Gender includes other psychosocial factors and level of education, social economic status that affect the way you perceive pain. Mental and emotional health, which are very much affected by the amount of sleep that you get, also changes your perception of pain. Having other diseases, especially diseases that contribute towards the buildup of inflammation and their associated medications, can also cause more pain perception. So when you put this all together, each individual's pain perception is going to be a little bit different, which makes it very difficult for us to study and draw conclusive findings about pain. Now, a good idea is to keep a pain diary, especially one that lasts 3 to 6 months or beyond, and be able to use the information from your diary to compare it to other common painful events and to your pain much earlier. So now we're going to delve a little bit more into musculoskeletal pain in general, and then talk a little bit more about the treatment of pain. So we're going to start off with bone pain. Now, this is Osteoporosis Canada webinar, so I have to talk about osteoporosis a little bit. Osteoporosis itself, or the process of developing a bone loss, does not actually cause pain. So it's not until you experience a fracture, it could be a slowly progressing fracture like a spinal fracture, that you start feeling pain as a result of a bone damage. Caused by fractures and other musculoskeletal injuries, bone pain can eventually accumulate. It can also originate from arthritis or joint damage. And the joints could be various types of joints, including your knees, your ankles, your hip, your spine, your fingers, your finger joints and your toe joints. They can all contribute towards pain that's related to your bones. So sometimes we think about arthritis as a disease of the cartilage within the joint, but it's actually not just the cartilage. The bone that is involved in the joint, which often are the two sides of the joint, are very much involved in the disease process and can contribute to bone pain. Now, a less common type of bone originating pain is a tumor related bone pain. So sometimes your tumor can migrate to a bone site or your bone marrow, and that's where it can also cause a bone related pain. So these are all examples of where bone can be damaged within different kinds of musculoskeletal conditions. Now, I already talked about some forms of arthritis, but inflammation is a large part of joint pain in arthritis, including degenerative types of joint arthritis. In addition to the bone pain that we feel, there's stiffness and inflammation that accompany joint pain. Usually it gets better with rest, but worsens with activity. So joint pain involves not only the bone, there are other tissues involved. So the cartilage, sometimes the ligaments, and also there's a wrapping around the joint, especially around the hip and the knee, called the synovium. This is the lining of soft tissue that surrounds the joint and protects the joint from further damage outside. So those envelopes often get inflamed, and you sense a lot of pain from those envelopes as well. In terms of muscle pain, we're all too familiar with strains and spasms and cramps, but there are other neuromuscular diseases that contribute to muscle pain, and sometimes infections or tumors can contribute to muscle pain. So in the bottom here, you can see an MRI scan of someone who had a muscle tear. So the tear can be complete or it can be incomplete, and it still results in an accumulation of inflammation or fluid buildup in the muscle. It can cause pain over time. Now, even after the healing of these muscle strains or tears, there can be a number of scar tissue accumulating in the site that doesn't get cleaned up right away. So chronic pain can also build up in these cases of muscle strains and muscle damage. Tendons and ligaments can similarly be torn or be partially torn, just like muscle. So these are strong bands of connective tissue that connects your bones together or connects your bones to your muscles. Very often, if you have a complete break in your ligaments, then you hear a loud pop. Skiers who tear their ACL and PCL in their knee, often they do hear this loud popping noise. Sprains, strains, and other overuse injuries contribute to also ligament and tendon pain. So we talked a lot about very common causes of musculoskeletal pain. These often result from injury, overuse or overloading, having poor posture or poor alignment, or sometimes it's congenital or you were actually born with it. There's also degeneration. So with aging, some of these musculoskeletal tissues just naturally wear out over time, or it can be self or externally triggered by inflammation. So when I say self, I mean autoimmune. So your immune system attacks itself, or you can have inflammation that's triggered by something from outside. So we also have that lingering problem of an unknown source of pain that may result from a previous event that has already healed itself, but we still have that central sensitization. So finally, we're going to talk a little bit more about the treatment of pain. So the first, I want to go backwards. Sometimes we focus too much on the pharmacological or the drugs. We're going to start a little bit about the soft treatments. So pain relief using meditation is actually a very powerful means of managing your pain. We can address your mental and emotional health. We can exercise mindfulness and deep breathing. And we can use imagery and just simply be in a warm bath, in a warm shower, and exercise or meditation. Meditation actually helps our nervous system calm itself, and it gives us the ability to reverse some of the central sensitization that I talked about earlier. Now, what actually happens during meditation? There are some research studies that talk about the process of good chemicals being produced in your nervous system. And these good chemicals can contribute towards the regeneration of new nerves, the replacement of old nerves, and resetting of the threshold through which we feel pain. We can also reduce sources of inflammation. Alcohol and smoking are really big contributors to inflammation. So I know it's going to be difficult to limit alcohol intake and for some people to limit smoking, but try to reduce it as much as possible. Another big source of inflammation is consumption of sugary drinks. So the amount of sugar that you're consuming, and when I'm saying sugar, I also mean carbohydrates, especially simple carbohydrates, like bread that is not high in grains. If you have a large consumption of these, not only do you risk getting diabetes, you also have a high chance of getting more inflammation or exacerbating existing inflammation. Getting adequate sleep. So sometimes easier said than done, but having 7 to 8 hours is ideal to have your body fight the inflammation that's in your body. And then here, exercise and being physically active, the recommendation is to have at least 30 minutes per day. And the exercise, it does impose a little bit of pain during the process, but it can help you fight the central sensitization that is built up. What exercise can also do, and all these other methods that I described can also do, is reduce your level of fat distribution in and around your muscles and also within your visceral organs. In fact, fat is actually an organ that produces a lot of our inflammatory molecules in the body. It contributes to inflammation, and as a result, it can also contribute towards pain. So reducing our sources of inflammation and reducing fat by doing these activities can really help with our perception of pain. The first type of medication that I will go into is corticosteroids. Steroids include prednisone, prednisolone, dexamethasone. You may become familiar with these when you're taking it for arthritis, either as an injected form or as a pill form. We also know that glucocorticoids, or these corticosteroids, are a risk factor for having osteoporosis or the loss of bones. When you take more than 2.5 milligrams per kilogram of your body weight for over 3 months, you are at a higher risk of having fractures and for developing osteoporosis. So these drugs can be orally consumed, but also injected directly into the joints. Now, the side effect of corticosteroids is you can have a buildup of fluid. It can have pressure on your heart. It can cause weight gain, especially in the stomach, the face, and the neck. It can also change your mood, concentration, and your behavior. So although it is a good anti-inflammatory for dealing with pain, especially pain at a very specific site, it can have some sources of damage. We know that glucocorticoids can also cause bone breakdown, and it also has an effect on muscle in causing muscle to be lost. So in terms of muscle-related pain, we have muscle relaxants. So these work specifically at the junction between your nerves and your muscle. It prevents your muscles from having further nerve stimulation, and it helps you relax as a result of blocking this nerve stimulation. This might address muscle-related overall collateral damage resulting from pain, or it can address just primary origins of pain that come from the muscle. The side effects are not usually that serious, but it could include drowsiness and fatigue. Now, the next class of medications is non-steroidal anti-inflammatory drugs, or NSAIDs. These are often available over the counter, and there are more prescription medications available for this. So these work on enzymes or proteins that are found within your body to block the inflammation process. Some of the side effects of NSAIDs include gastrointestinal system, or the buildup of ulcers within your stomach. stronger and less selective NSAIDs might have an impact also on the cardiovascular system. So it could, I think back then there was celecoxib, and there were black box warnings of heart attacks and stroke. And then NSAIDs can also have a short-term impact on fracture healing. So if you just recently had a fracture and you're taking NSAIDs for pain, it might have the ability to prevent the union or the healing of the fracture. Now, the next class of medication is very familiar for those who have very severe pain, especially. So these are opioids. These are classified as a drug that's made for stronger pain relief. It acts on the opioid receptors on the specific nerve cells, blocking the pain messaging to the brain. These are very strong acting drugs, but it also correspondingly have very strong side effects. So this includes commonly constipation, nausea, and vomiting, difficulty breathing at night. So for those who have sleep apnea, it can exacerbate those symptoms of breathing at night. It can cause dizziness and confusion, and as a result, it could increase your risk of falling and therefore fracturing if you already have osteoporosis or weak bones. Now, addiction and fatal overdosing is definitely a major side effect of opioids. And so doctors have been limiting their prescription of opioids. When you have children in your house, this becomes a more challenging issue. So making sure they don't have access to these drugs is another challenge that you have to deal with. Anti-seizure medications, you might not think of it as a method of pain relief, but these are drugs often used for Parkinson's disease or other similar neurological disease. It is very useful for treating neuropathic specific pain. So remember, this is pain that's originating from inside of the nerves or can shoot down a nerve. It does so by reducing nerve sensitivity. The side effects of this include drowsiness or dizziness and some fatigue. Now, some of these pain medication options are better for one type of pain versus another type of pain. So for your muscle relaxants, your NSAIDs, opioids, and even surgery, these are usually more effective for somatic pain, or pain that results from damages within your skin, muscle, bones, ligaments, and tendons. Okay. Now, for the visceral organs, if you have pain originating from the organs, we can use similar drugs, but have a stronger dose or having a combination of these drugs. If your pain comes really from the nerves, it's neuropathic pain, then we can select drugs that target the nerves and your brain chemicals. And this includes your muscle relaxants, but also anti-seizure medication. Now, there are other forms of medication that we can consider. So there is a lot of talk about cannabinoids or cannabis. Cannabis actually can be distinguished in two chemicals that are active in the plant. So there's the cannabidiol, which is CBD for short, and also tetrahydrocannabinoid, which is THC. CBD is the non-psychoactive component of the cannabis plant. So this is the part that gives you the pain relief and the numbing effects, but without the part that gives you the high. THC, or the tetrahydrocannabinoid, is the component that is associated with the high. So if you really want the component that only gives you the pain relief, then you want a pure CBD type of product. So you can have CBD oil, which can be taken orally in the form of food. So you can drop it into food before you, after you finish cooking. It can be sold in gummy forms, or you can just put a drop of oil under your tongue. CBD also comes in creams and ointments, or as a patch that you can put on parts of the body where you feel pain. Now, some of the side effects include having dry mouth, reduced appetite, feeling drowsy. So you should really avoid driving after you take this. And then it also has potential effects and interactions with blood thinners. Okay, so when you go to some of these cannabis stores, you have the option of selecting only CBD-based products. You want to avoid any products that have this specific symbol on the right showing that there is THC. THC, remember, it's the component that gives you the high. So by regulation in Canada, CBD products that are only CBD without THC should only have less than 0.3% by concentration of THC. Now, you might have seen hemp oil in the supermarkets. This is different. This is not cannabis. Hemp oil is rich in omega-3 fatty acids, but it doesn't actually have any CBD. So the costs are very different. And the effects are also very different. So what is the evidence right now for using cannabinoids? Currently, there are 17 drug trials for CBD for treating musculoskeletal pain, and high doses of CBD investigated across the 17 studies. When you summarize all of it, seems not to have any potential effect on pain relief. Now, there are some smaller studies and some animal studies that earlier showed some positive effect, but it may be only successful in a subset of patients. So far, we don't have very good conclusive evidence for pain relief for using CBD oils or CBD products. However, that's not to say that it might be more effective in a specific population, but we just have not investigated in research. Stem cell therapy is also another potential alternative method. Stem cells are often harvested from the marrow or from the plasma of your blood. It is shown in the lab to regenerate bones, cartilage, tendons in earlier and smaller experiments. However, it requires some modification in the lab setting. You could also gather these cells from a donor or harvest it from yourself. However, just like the CBD trials, there's currently no conclusive drug trial evidence for its effectiveness. There have been a number of studies being done, but when you summarize all the evidence together, there is no conclusive evidence, which means it is not recommended currently for pain relief as a therapy. Currently, Health Canada and FDA do not recommend stem cell therapy for the purpose of musculoskeletal pain or arthritis pain. And you will see that there's a lot of stem cell therapy companies being advertised and advertising direct to consumer. In Canada, that is illegal, but in the States, there are a lot of direct to consumer advertising for these clinics. So only trust referrals that you get from licensed doctors and not any of these advertised clinics. There are opportunities to participate in a clinical trial if you are an eligible candidate, but currently there is no conclusive benefit of having stem cell therapy on pain. More research and recent developments from research have also informed us that musculoskeletal pain can be worsened by fat within the vicinity. So I already talked about fat being a major player in promoting inflammation. So this is especially true when you have fat being infiltrated in parts of the body where you feel the pain. So for example, if you have back pain, infiltration of fat into the muscles around your back can also worsen the pain. So fat is known to release chemicals to recruit your immune system cells and cause further inflammation. And this is still the case in non-overweight individuals. So you might think that, oh, because you're not overweight, you might not have an accumulation of fat, but that's actually not true. When you don't exercise, you have an accumulation of fat, especially when you lack sleep, when you lack exercise, and when you consume a lot of alcohol, smoking, or high sugary products. So all this together can worsen the amount of infiltration of fat into your muscles and bones. Accounting for sex and gender can also help us account for the differences in pain between individuals. So we briefly talked about the endurance, the sensitivity, and willingness to report pain in individuals. And for some diseases, these painful origins are actually different between the sexes, and allows us to potentially better pinpoint the sources of pain. So for example, in arthritis, we are seeing more and more that postmenopausal women may have pain originating from the bone rather than from the joint tissues. So these research developments can really guide us further in our journey to better understand musculoskeletal pain. So I'd like to end off with giving you an overview of how to talk to your doctor about musculoskeletal pain. So this should be a little bit of a checklist that you can go through. So you can mention, is your pain acute or is it chronic? So has it lasted for more than 3 to 6 months? Which part of the body is involved? And is the pain superficial or is it deep within your body? Does it shoot up a body part or is it concentrated within a specific area? Does it come and go or is it constant? Or maybe you have kept a pain diary so you can tell the doctor a little bit more about how often you feel the pain and whether the pain comes and goes. Has it affected your muscles? Do you have knots in your muscles? Have you become more sensitive to touch? Are you less resilient to more common sources of pain? Has it affected your sleep, or has it made you more tired or more weak? So these are all really good questions to answer before you get to your doctor's office. So to end off, I'd like to better understand the audience here a little bit. I know many of you are interested in this seminar because of your musculoskeletal pain that you're dealing with, either acute or chronic. A lot of the sources of pain come from bone or muscle and joint problems. And this seminar has gone over a number of these disease conditions. But for my research, I'm very much interested in individuals who have multiple of these conditions, especially osteoarthritis and osteoporosis. So I'd like to set up a poll here. You can complete this poll. So the question asks, do you have both osteoporosis and osteoarthritis? And I understand there are over 500 people on the seminar, so it's really good for me to get a better understanding of how this combination of diseases is distributed in our audience. So just select yes if you have both diseases and no if you don't. So I'll give you a minute to complete this. Okay. Maybe a few more seconds here. All right, and here are our results. Wow, so close to 50% of our audience said yes to having both. This is very interesting. So I'm going to take this back to my research. So according to my research, up to 30% of individuals have both osteoporosis and osteoarthritis. It's funny because doctors used to think that osteoporosis and osteoarthritis are actually protective of one another, and it's not possible to have both. But we're learning more and more that, in fact, people can have both diseases. So we do have to worry about our bone health when we have joint problems. And very often, your joint health involves bone at the joints. So we have to really think a bit more about that. So I understand we do have some questions. I wanted to end off here with some additional resources, some resources on pain in the context of osteoporosis, so fracture-related pain, some resources on stem cell and plasma therapy for arthritis, and evidence for it and recommendations, how to do proper exercises when your joints are in pain or when you have multiple sites with pain. So this is really useful. I highly recommend the second link here, which shows you specific exercises. And then resources on pain management with cannabis. And finally, some resources on supplement use for musculoskeletal pain. So this includes chondroitin sulfate, glucosamine, vitamin D, even turmeric in its contribution to limiting inflammation. Okay, so I'm going to hand the floor over to Tracie to ask some questions.
Thank you so much, Dr. Wong. That was really, truly an excellent presentation. I know we only have time for a few questions, but before I ask you the first question, I'm actually answering a question. It's the one I got. We are recording this webinar. So please know that as a registered participant, you will be getting the link within a day sent to your inbox, and you can rewatch this webinar again if you'd like, or if you know someone who missed it, it will be available. So not to worry, this will be available. All right, so for our first question, which kind of follows on the heels of the poll, Dr. Wong, what kind of medications are for osteoporosis and osteoarthritis pain? There are people who are saying that they have constant pain in their back, hips, knees, joints, and muscles on a daily basis.
All right, thanks so much for that question. That ties really nicely to our poll. So it's important to follow your doctor's directions to appropriately treat your osteoporosis. Everyone's treatment plan may be a little bit different. So you can use osteoporosis medication. There may be prescription of an exercise plan, which could include resistance exercise. But sometimes, especially if you have had a fracture, it should be better tailored by a physiotherapist to be safe. Food may be rich in calcium and vitamin D. So those different treatment plans may be appropriate for osteoporosis. And by dealing with your overall bone health, it could also be beneficial for your bones at the joints. So in fact, some evidence have been accumulating for osteoporosis medication being also beneficial to the progression or limiting the progression of osteoarthritis. Some pain medications like NSAIDs, the non-steroidal anti-inflammatory drugs like Tylenol or Advil, etc., could interfere with fracture healing. So this is especially true in the first few weeks after a fracture, especially when you use it at a high dose. So you have to be very careful with use of NSAIDs right after a fracture. There are other medications that reduce inflammation, like glucocorticoids or steroids, including prednisone. However, like I mentioned during the presentation, it can cause further breakdown of your bones and muscles if you use it over a long term. So although there is currently no recommendations against using these medications, you have to be a little bit careful and talk to your doctor about its potential side effects.
That's wonderful. Thank you so much. We have time for a couple more questions. Let's talk about supplements. Have there been any clinically proven studies about supplements helping in reducing or eliminating musculoskeletal pain?
That's a really good question. Now, in general, nutritional studies or supplement studies are very difficult to do. And very often they rarely result in a very conclusive finding. There have been some studies on vitamin D, chondroitin sulfate, and glucosamine, which I have provided the resources for in the additional slides. But like we mentioned in the presentation, the evidence is a bit mixed. Some studies show an effect while others don't actually show an effect. It is believed that it may have a positive effect on pain in a subset of patients, but we still don't have a clear understanding regarding which set of patients. The problem with nutritional studies in general is that the effects are usually very small, and so you need a very large population to study it. And often we don't have the money or the resources to recruit such a large population. And also because it is very often a nutrient, almost everyone is exposed to some level to the nutrient from taking food. So it is a bit challenging to account for those differences in exposure, even between people who have a placebo versus the actual drug in a clinical trial.
Thank you for that. All right. How about this question? How does osteoporosis affect bone healing post fractures? For example, a post-op recovery for ORIF of elbow.
That's a great question. Osteoporosis can actually slow the healing process after a fracture, especially because of the higher bone turnover. It is important to follow up after a fracture to see what treatment options your doctor would recommend and for treating your overall bone health in general. Currently, there is the Fracture Liaison Service, which is helping ensure all patients with a fracture after age 50 are evaluated for risk factors for osteoporosis and future fractures. But if you're under the age of 50, you should really still pay attention, because chances are if you have a first fracture, you're more likely to have another fracture.
Okay, and we have time for one more question. Can you discuss the neurological connection of pain and how pain sensors in the brain can be responsible when a site has no specific injury?
Yeah, so I mentioned this a little bit, and this process is called central pain sensitization. So it's a concept that's due to the structures in our brain, in our spinal cord already having been changed as a result of our pain. And these changes result in a larger number of pain receptors, more chemicals being released by your nervous system. And the result is that you end up with a lower threshold for delivering those painful messages to the brain. And this is what's called central sensitization. So it's also very common when you get a cold. So when you get a cold, you start coughing, and then your set point or your threshold for a cough has been lowered. So you will find that after a cold is gone, you will continue to cough for some time until your body has finished resetting your threshold to normal. But for pain, this is actually even worse, right? The process is difficult to do for your nerves in terms of pain. It will require a combination of adaptive exercise, good sleep, maintenance of your mental and emotional health by meditation, good nutrition. And the nerves in general take a very long time to repair itself. And we're talking about in the order of months. And so for these types of pain mechanisms embedded very deep within the whole nervous system, it may take even longer. So we want to stress the benefits of exercise. And in the additional slides, you can see that there are resources that you can watch. And in terms of exercise, you can focus on three main things. So adaptation, overloading, and progression. So if you watch one of the videos that I recommended, they will go over these specific topics of how to do exercise. Exercise is supposed to hurt a little bit. And every time you give yourself that little bit of challenge, you will have overcome that challenge. And the next time you go back and take a look at what you had done in terms of an exercise before, you're becoming better and better at dealing with these loads. So you can develop a program that is suitable for you, even if you feel pain, especially if you have a physiotherapist, to make sure you do this safely. But the key is to challenge yourself a bit at a time, starting with only what you can handle safely and progressing carefully until what used to be a challenge may no longer be the case.
All right. Well, Dr. Wong, thank you so much. That was truly a very informative presentation. I just want to let everybody know that we have 3 more webinars coming up in 2023. Our last cooking demo, which is focusing on protein, which is Wednesday, December 6th. And then we actually have a follow-up webinar on the importance of protein with Lucia Wheeler, who's a registered dietitian, on Thursday, December 7th. And on December 8th, we have Dr. Rowena Rideout, who is going to let you know what you need to know about the 2023 Clinical Practice Guideline on Osteoporosis, which was just released. And you can register when you visit the website, osteoporosis.ca. It's on the homepage, or you can go to the events calendar to register. We also want to thank everyone who has joined us today. If you have not already subscribed to the e-newsletter, you can get information directly to your inbox. So you can just, again, go on the homepage, go to the top right-hand corner and click subscribe. We're on Instagram and Facebook, where we also post information. And again, if you've registered, you will receive the recording of this webinar, and it will be available on the OC replay page. So again, Dr. Wong, thank you so much. And to everyone else who's joined us today, we look forward to seeing you on our next webinar. Have a great rest of your day, everyone. Take care. Bye-bye.
Thanks for having me. Bye-bye.